everybody. I'm Dr. Roshni Chakravarti. I am the moderator of this session. Today, the discussion today is going to be about Dapagliflozin, which is a SGLT2 inhibitor, and it is used in the treatment of type 2 diabetes mellitus and has many other unique benefits. I am currently attached with critical care team with AMRI Hospital and also passed my MBBS in 2019. So it is my pleasure to be a part of this session. So diabetes, as we know, needs a 360-degree approach for treatment perspective. And this drug is known to have many benefits for patients who have also heart failure and also have reduced ejection fraction with time. So it has shown many benefits. So this drug has become very important. So I would like you to introduce to the speaker of this session for today, a renowned endocrinologist, Dr. Supratik is the director of PSK Diabetes and Endocrine Center in Calcutta, also the consultant for Department of Endocrinology with AMRI and Apollo Sugar Hospital. He has numerous publications, international, national, to his name, and has been attached with many third and fourth phase clinical trials, and also the famous global Ramadan trial. He's also been awarded with the Rising Star in 2021 by the Academic of Diabetes, Indian Academy of Diabetes, and also has received an RSSDI award for Best Innovation in Diabetes Care during the challenging times. He's also been awarded for Best Diabetes Awareness in 2017. He's been the organizing chairperson for International ID2 Summit in 2022 and the National SGLT2I Symposium in 2020. Also been a part of the organizing committee for Diabetes India 2021. He's been a speaker at many national and international conferences and also has been a scholar all his life. So it is our pleasure to have him with us. And I would request Sir to take over the session from here.
Thank you so much, Dr. Roshni, for all your kind words of invitation, and a warm welcome to all of you who has joined today. So today we're going to talk about SGLT2 inhibitor with primary focus on Dapagliflozin, and we are going to talk about why we have moved from a glucose-centric approach to a more organ-centric approach. So we know that now we have moved away from actually treating the blood glucose to target levels, and rather what we do is treat diabetes based on the pathophysiology. We also know about the fact that anyone with diabetes is at increased risk of cardiovascular disease, and almost 40% of the diabetic patients also eventually develop diabetic nephropathy. So it's essential that we have a molecule which is not only efficacious in terms of achieving the target HbA1c, but at the same time, it has got pleiotropic benefits in terms of reduction in body weight in the obese or overweight individuals. At the same time, have modest effects on the blood pressure reduction over on top of the standard of care, and also have favorable profile when it comes to treating dyslipidemia, cardiovascular, and renal systems as such. So that scenario, if you look, I think SGLT2 inhibitor kind of fits in very well because it's a versatile molecule. So it is sort of modest in terms of reducing the HbA1c. However, it's got many more sides to it. And what is important is to have a molecule which not only treats diabetes based on the pathophysiology, but a molecule which has a sustained effect over time. What we know is that SGLT2 inhibitor has got a very unique mechanism of action. And if you look at the defronzose ominous octave, it sort of targets one area which is not covered by any other molecule, and that's the kidneys. And the best part is that it's insulin independent in action. So progressive nature of diabetes necessitates a combination therapy sometimes. So sometimes we see that one molecule is not good enough. So when you talk about SGLT2 inhibitor, it's quite a good molecule because you can combine with any other OHF for that matter, even with injectables like GLP-1 receptor analogs or even insulin. So you can place SGLT2 inhibitor at any time of the diabetic spectrum, whether it's a newly diagnosed individual where you need to sort of address the hyperglycemia. At the same time, you want to minimize hypoglycemia. Or at the opposite end of the spectrum, where a person has been having diabetes for a prolonged period of time and have been on insulin treatment. And the idea is to provide a molecule which is not only going to sort of negate the bad effects of insulin in terms of weight gain, but at the same time has the potential to cut back on the insulin units. We also know that initially, we do not have any problems with the insulin. There's a lot of circulating insulin in the system. However, problem arises is that we, being thin fat individuals, as compared to our Western counterparts, we carry a lot more fat around our waist. And because of that, we are insulin resistant. And SGLT2 inhibitor, in fact, addresses that pathophysiology, and it targets the visceral fat, and that's why it brings down the insulin resistance. So SGLT2 impact the metabolic components of diabetes, including hypertension, dyslipidemia, and obesity. And the common soil to all of these conditions is insulin resistance. Sodium glucose cotransporter 2, as they are called, are preferred drugs in patients with diabetes and coexisting conditions like hypertension, dyslipidemia, and obesity, for the reasons that we had just mentioned. Now, SGLT2 inhibitors, and if we are talking about the proposed mechanism of action, we call it a diabetic diuretic, and it has got two different mechanisms. One is the glycosuria, by which we mean that we pee out glucose from the body, and because of that, we're losing calories. And because of the negative caloric balance, we are actually reducing the total body fat, especially we are targeting the visceral fat. And in a sense, we are actually reducing the inflammation and fibrosis, which is part and parcel of the diabetes per se. So glycosuria at the same time helps us achieve the target HbA1c. It reduces the inflammation and glucotoxicity that comes with it. And at the same time, it causes uricosurium. So anyone with increased uric acid levels, this is very helpful over on top of achieving the glycemic control. So in a sense, we are protecting the heart, and we are also preventing atherosclerosis. And there's a lot of crosstalk between the heart and the kidney. And natriuresis is one of the areas. Because of natriuresis by SGLT2 inhibitors, what we achieve is that there is a modest reduction in the systolic and diastolic blood pressure. So the systolic comes down by about 4 millimeter mercury and diastolic by about 2 millimeter mercury over on top of the standard of care. And that essentially reduces the atrial stiffness. Natriuresis also increases the tubular-glomerular feedback, and that causes afferent arterial constriction. And intraglomerular hypertension is negated, and that reduces the hyperfiltration that is associated with the initial phases of diabetes. There's a decrease in the plasma volume, and that reduces the myocardial stretch. And we know that because of the body weight loss and because of all the beneficial effects that we have been talking about, the ventricular arrhythmias are minimized, and activation of ACE2 angiotensin inhibitors are also part of the procedure, because of which the ventricular arrhythmias are taken care of. So no sympathetic nervous system activation is associated with the use of SGLT2 inhibitor. Dapagliflozin effects on the anthropometric and metabolic variables. We had already talked about the pleiotropic benefits like weight loss, a modest reduction in the body blood pressure, as well as the metabolic variables. We know that there is a reduction in the body weight by up to 4 kg, as has been seen from the real-world studies. Significant elevation in the adiponectin levels, reduction in the C-reactive protein levels, and thus we are addressing the inflammation that is coexistent. We know that diabetes being a pro-inflammatory state, and reduction in the systolic blood pressure, as we had mentioned, to a modest 4 millimeter mercury systolic and 2 millimeter diastolic. Over on top of that, we already talked about the decrease in the uric acid levels, and that might be helpful in those who are having increased uric acids. So how does it protect the heart, the kidneys, etc.? We know that with the kind of data and dedicated heart failure trials, we know that dapagliflozin has been established as one of the treatment modalities for reduced ejection fraction patients, that is ejection fraction less than 40%, and ongoing trials are there to see whether it's equally effective for preserved ejection fraction. Also, we know that there is low risk of worsening of heart failure or hospitalization due to heart failure with the use of SGLT2 inhibitors. And this happens for both diabetic as well as non-diabetic individuals. And that's why it's now a part and parcel of any of the guidelines that you see. And it's become one of the 5 pillars for treating heart failure. So exerts beneficial effects compared with placebo on urinary ACR in patients with normal, micro, or macroalbuminuria. So there's regression of micro to normal albuminuria and regression of macro to microalbuminuria. And we also have dedicated renal outcome studies with dapagliflozin. And these are sort of terminated prematurely because of the overwhelming beneficial effects that were being perceived with the use of dapagliflozin in the CKD patients. So the proposed mechanisms of dapagliflozin in cardiac and renal protection are reduction in the intraglomerular pressure due to increased sodium delivery to the macula densa, leading to constriction of the afferent renal arterioles. There's reduction of the kidney fat deposition, which is considered ectopic fat that promotes diabetic kidney disease progression. Also, there is reversal of hypomagnesemia, which is correlated with a more rapid decline in the renal function. The other proposed mechanisms are reduction in the inflammation, oxidative stress, and oxygen-consuming transport workload. We have already mentioned about natriuresis and blood pressure lowering effect, and increase in the fasting glucagon, and increase in the erythropoietin levels that exhibits direct renoprotective effects. To summarize, the key messages that we wanted to deliver today is diabetes patients are prone to developing kidney as well as heart diseases due to multiple effects of hyperglycemia. So both the micro as well as macrovascular complications are very common with diabetes. We know about the ticking clock hypothesis, where the macrovascular complications set in well before the diagnosis of type 2 diabetes, and the microvascular complications set in after the diagnosis of diabetes. And dapagliflozin is probably one of the molecules which addresses both the micro as well as macrovascular complications very effectively. Ideal glucose lowering drug should not only enhance the glycemic control, but also improve body weight, blood pressure, dyslipidemia, cardiovascular, and renal outcomes. So we already said that we are moving away from the glucocentric approach to an organ protection. And glucose-lowering therapies demonstrating effects beyond glycemic controls are needed, and those are the kind of things that were wanted in the management of type 2 diabetes. And with the advent of SGLT2 inhibitors, we have such a versatile molecule in place, which not only targets the glycemia, but also have multiple pleiotropic effects. Dapagliflozin exerts beneficial effects on the weight loss. We have seen up to 4 kg weight loss as in the previous slides with various real world as well as RCTs, and anthropometric parameters like the body weight, etc., also improve with the use of dapagliflozin. And now dapagliflozin has been established treatment in heart failure patients, both diabetic and non-diabetic individuals. Similarly, for the CKD patients, we have enough data to use dapagliflozin in various stages of CKD, even up to eGFR of 30. The whole idea is to bring in dapagliflozin early and rather than later. But even if you are at advanced stages of CKD, the person still gets organ protection while you're using dapagliflozin, if not the benefits in terms of glycemic control. So ensure that you are introducing dapagliflozin early into the system, and also keep continuing dapagliflozin so that the patient gets benefit by prolonged use from it. So with this, I conclude my study and hand the mic back to Dr. Rashni. Thank you for your kind and patient hearing today.
To conclude this session, thank you to our speaker for this vital knowledge about dapagliflozin. It's very important for us to know the effects that it is causing in the organ approach for cardiovascular as well as the renal system. I would also like to thank for giving me this opportunity to moderate the session. Thanking Koya Pharmaceuticals and Carbon Solutions for arranging this session. And yes, thank you.
Stay safe, everyone. Thank you, Dr. Rashni, and thank you, everyone. Bye-bye.